distinguished guests as well as ladies and gentlemen. Welcome to the second day of our Paediatric Rheumatology course, and a very good morning to everybody. The first session for today will be chaired by Dr. Monica De Silva, Senior Consultant Rheumatologist and Rehabilitation Specialist in NHSL. Over to you, Madam.
Good morning to you. This is the second day of these interesting sessions on pediatric rheumatology, and this session is today on autoinflammatory diseases, diagnosis and management in resource-poor setting by Professor Sulaiman Mayouf. Consultant pediatric rheumatologist, Kim Faisal, Hospital and Research Center from Saudi Arabia. And after that, there will be a case presentation by Dr. Tilni Hemachandra, consultant rheumatologist, and this will be followed by Q&A session. Okay, over to you, Professor.
Thank you very much for this kind introduction, and again, thank you for the kind invitation, and good morning, everyone. My talk today, as you heard, the clinical approach to autoinflammatory disorder, and I will use this outlines to address my talk. I will give a brief background and the basis of systemic autoinflammatory disorder and the evolution of the concept of systemic autoinflammatory disorder, and will end with approach to common systemic autoinflammatory disease and treatment. Let me start with this case from my clinic. This is a 3-year-old girl with recurrent febrile episodes. These episodes began at 9 months of age, recurring every 2 to 4 weeks and lasting no more than 4 days. During each episode, she used to have high-grade fever up to 39 degrees centigrade associated with abdominal pain and bilateral knee arthritis. She had minimal response to antipyretics and no improvement with antibiotics. During one of her typical episodes, blood tests showed the following result: high white cell count and platelet, as well as high inflammatory markers. Interestingly, she was between the febrile episodes, she was healthy, well-looking, and also her lab tests were normal. So this is very important point. You need to consider it in these cases. So let me just highlight the two concepts. I think everyone is familiar with autoimmunity, and we don't need to discuss that, but maybe the new concept, what we call it, autoinflammation. Now my question, are both the same? What do you think? Maybe the answer is yes and no. Yes, in sense there are similarity between the two concepts or two entities. Both do have immune system malfunction directed against self, and this is the reason we call it auto. And both share similar symptoms involving multi-system, mainly the skin and musculoskeletal system, and both include monogenic and polygenic disease. However, there are significant or important differences between the two entities in the sense of the autoinflammatory disease, typically they lack of autoantibodies, while autoimmune disease, they have high titer of autoantibodies. I will take examples for each type. The autoinflammatory disorder, we'll call it FMF, and autoimmune disease SLE. So you cannot imagine SLE patient without autoantibodies. On the other side, FMF, typically they don't have autoantibodies. And the autoinflammatory disorder, the predominant effector cells are monocytes and neutrophils, while the autoimmune disorders associated with autoreactive antigen-specific T lymphocyte, B and T lymphocyte. Typically, autoinflammatory disorder, they presented with unprovoked attacks of fever, while the autoimmune disease, typically they have progressive disease if not treated properly. And the most important point, autoinflammatory disease due to defects in the pathways of innate immune system, while the autoimmune disease, the defect in the pathway of adaptive immune system. Now, these are the main differences between the autoinflammatory and autoimmune disease. So if we need to summarize it, the autoimmunity malfunction in the adaptive immune system, while autoinflammation or autoinflammatory disease malfunction in the innate immune system. This figure showed you the autoinflammation. I told you the FMF is the best example, but other diseases like TRAPS and CAPS, all these are autoinflammation, and you can see it's related. I don't think this is working anymore. You can see these diseases under the umbrella of autoinflammation linked to the innate immune system, or the autoimmunity like IBEX or SLE associated or due to adaptive immune cell pathogenesis or defect. But there are diseases probably overlap between the two entities. Now, we have to remember innate and adaptive immune system work closely together, and this is the reason you saw some overlap between the two diseases or entities. And it's important also to remember the autoimmune and autoinflammatory disorder are frequent features or presentation due to inborn error of immunity. So those who have some problem in their immune system in terms of immune deficiency, it's not unusual to see present with some autoimmunity or autoinflammatory manifestation. So probably this is enough background. Let me move to the systemic autoinflammatory disorder in more details. The first known systemic autoinflammatory disease, which is FMF, was described in 1945, a long time ago. However, the term autoinflammatory was introduced in 1997 after identifying the genetic causes of FMF and TRAPS to describe inflammatory disorders marked by innate immune system dysregulation independent of adaptive immune system. So the first disease was long time described, but the concept or the term of autoinflammatory relatively new in 1997. There is another landmark, which was in 2001 when the recognition of interleukin-1 dysregulation found as a key factor in certain autoinflammatory disease, namely NLRP3 or what we call it CAPS. From there, they found interleukin-1 is one of the important key factors in autoinflammatory disease, and based on that, the treatment was tailored for this and managed accordingly. Saying that, there is a stereotype about autoinflammatory disease, and that's what we teach our students. And this is the classic or the stereotype of systemic autoinflammatory disease. Early onset, You may see these cases in infancy or childhood. They present with unprovoked recurrent fever episodes, share common phenotypes, multisystem rash, sinusitis, arthritis, and importantly, completely well, including lab result in between attacks. So you have to take good history. If you can see the lab result from other hospitals, it will help you to consider this diagnosis. And without evidence of pathogenic autoantibodies or autoreactive T lymphocyte. Now you have to remember the ANA positivity. It can be present in even normal people, up to maybe 10 or 15% of normal population. So presence of ANA without good explanation, probably you will not take it seriously unless you can find other associated lab result abnormalities. So all these findings or manifestation due to sterile inflammation arises from antigen-independent hyperactivation of immune pathways. And this is due to dysregulation of the innate immune system. Since the discovery that FMF is caused by mutation in the pyrene encoding gene, several new monogenic systemic autoinflammatory disease have been identified. However, the concept has been expanded beyond the hereditary recurrent fever syndrome to include several Mendelian diseases like Blau syndrome, Majeed, DIRA, and more than that, disorder of uncertain genetic etiology, like Behçet disease, systemic GIA. There is concern, is it autoimmune or autoinflammatory, although many people thought it is autoinflammatory in nature because of the role of interleukin-1. And more than that, all diseases like gout disease reclassified as autoinflammatory disease. And nowadays we consider also adult diseases like adult onset disease as autoinflammatory disease. So with that expansion, people try to reorganize themselves and they classify it undifferentiated multifactorial because there is no single gene responsible for the disease. And of course, the most common or the typical one is monogenic or related to single gene defect. And the monogenic systemic autoinflammatory disease genetically diverse. It can be due to loss of function of the variant, and it can be complete, like amorphic or partial hypomorphic mutation. It can be gain of function. It can be Mendelian pattern of inheritance, either autosomal dominant, autosomal recessive, or even X-linked inheritance. Saying that we don't have limit for these diseases, and theoretically there could be as many monogenic systemic autoinflammatory disease as there are gene variants and related immune pathways. So if there is a new discovery and proved by functional assay, that means there is a new autoinflammatory disease, and so on. So with the new discovery of the gene variant, with new discovery of immune pathways, means we'll add more diseases to the list. As I said, the interleukin-1 beta discovery made a landmark in the map of autoinflammatory disease. It has strong association with systemic autoinflammatory disease and play a significant role in their pathogenesis. However, with advances in understanding and new molecular genetic discovery, other mechanisms have been uncovered a variety of innate immune pathways led to overproduction of various inflammatory cytokine, namely tumor necrosis factor, interleukin 18, type 1 interferon, and so on. So this figure summarizes the genetic defect and related pathomechanism and inflammatory signals pathway in systemic autoinflammatory disease, including inflammasome platform and related interleukin 1 and tumor necrosis activity, as well as type 1 interferon. This figure showing the main pro-inflammatory cytokines, including interleukin 1, tumor necrosis factor, and interleukin 18 and others. And this showed also the pathways, for instance, interleukin 1, mainly inflammasome, and the best example, as I said, FMF and CABs. For for type 1 interferon, you will find many diseases like SAVI and other diseases. For tumor necrosis factor, you may consider also other diseases like autoimmune, although these are very rare entities. Now, this is the classes of monogenic systemic autoinflammatory disease, the inflammasome and related tumor interleukin 1, type 1 interferonopathies, NF-kappa-B related disorder, and cytokine signaling disorder. In my opinion, these can be reclassified, and I will call it classic systemic autoinflammatory disease and the new systemic autoinflammatory disease. Because if you recall the stereotype of autoinflammatory disease, typically this is fit in inflammasome and related interleukin 1, while others probably they will not follow the same pattern. So people may get confused when they talk about autoinflammatory disease. You just said this is periodic attacks, in between they are okay, and the lab results are okay in between the attacks. However, you just mentioned many diseases, you will find they have progressive and persistently high inflammatory markers even during the attacks, and they have progressive disease. So what is the answer for that? I think autoinflammation is not all or none. So probably some of the disease or entities showed autoinflammatory process. However, they may have also autoimmune disease because the underlying immune patho or mechanism are overlap between, and more than one pathways are involved in these diseases. So we know that this schematic illustrates probably the potential pathways in a patient with dysregulated immunity, and patient with immune dysfunction. He may follow either autoinflammation, immune deficiency, or autoimmune immunity with allergy. And I may add also malignancy in those patients. They may also show malignancy because of the immune system dysfunction. Now, the newly discovered systemic autoinflammatory diseases are complex. It's not simple like FMF. You can make a diagnosis based on the clinical manifestation. They are genetically defined disorder, increasingly recognized, and the genetic defects that regulate NF-kappa-B signals like DADA2 or autoimmune. There are mutations in gene that related to type 1 interferon amplification. So the inflammatory response is a mix of innate and adaptive immune dysregulation, and these disorders ultimately exhibit phenotypic feature atypical for systemic, or I will call it classic systemic autoinflammatory disease with numerous explanation. Let me just conduct quick comparison between the classic systemic autoinflammatory disease and the new autoinflammatory disease. So we'll take FMF as an example of inflammasome or interleukin-1 related disease. Typically, they have unprovoked recurrent fever. They present with serositis, arthritis, and rash. It can be articulated rash or erysipelas rash. They have GI symptoms because of the serositis. They may have neurological involvement, but it's not common. And they have elevated inflammatory markers or acute phase reactant and serum amyloid A mainly during the attacks. If not treated properly, they may have high systemic serum amyloid A because of the accumulation of this protein. And in regard of brain imaging, typically they have nothing there with the inflammasomopathies. Now, for interferonopathies, if we take like a cardiac gout here as an example, typically they have Torse-like syndrome without congenital infection. They have peripheral vasculopathy. They have Raynaud's phenomena. They have paniculitis. They may have also positive autoantibodies like rheumatoid factor, ANA. They may present with autoimmune-like lupus-like phenotype. They have interstitial lung disease, and they have devastating CNS involvement, and also they may have white matter changes and intracranial calcification. So there are different between the two entities, although both entities under the umbrella of autoinflammatory disease. So you have to be careful when you make a diagnosis of autoinflammatory disease. Is it the classic one or the new or interferon pathway related? So what is the prevalence of these diseases? Of course, this is very, very rare. If we with exception of FMF, especially in certain areas. FMF is common in certain areas, especially in Mediterranean fever. However, the others is very rare, so you don't feel guilty or you are not practicing real rheumatology if you don't see these cases, because in busy clinic, in a tertiary hospital, they may have such cases, but in general hospital, probably they will miss it, or maybe they don't have enough referral because the general pediatrician or family medicine will not consider it as a differential diagnosis. So the key here is clinical suspicion. All the time you need to have high index of suspicion, otherwise you will miss the case. Now, when should systemic autoinflammatory disease be suspected? I think this is more practical and we have to be aware about it. Number one, early onset symptoms, especially with positive family history, rapid appearance of unexplained fever, this is what we call it, unprovoked attacks. Other features may include rash, serositis, arthritis, uveitis, repeated attacks, and lax senility, typically 4-6 attacks per 9 or 12 months, and complete well-being attacks between attacks. Again, this is for the classic, but for the new or atypical cases, you need to keep high index of suspicion, especially if there is unusual manifestation like interstitial lung disease, CNS involvement, and brain calcification. I think when you encounter with a patient, there are few things you need to ask. Of course, good physician will ask everything, but this is maybe directed to the case of autoinflammatory disease. I will not go through it, I will leave it for you to read, but also there is things to check in the physical examination, and probably you need to check for the lab from the previous labs. As a comparison, it's part of your assessment as well. Now, the key points of workup. The first step in the investigation of systemic autoinflammatory disease is exclusion of non-systemic autoinflammatory disease, mainly infection. malignancy and autoimmune disease. So you have to be careful about it, and of course, if there is immune deficiency not associated with autoinflammatory or autoimmune manifestation. And the lab test may provide clues to the diagnosis and categorize of systemic autoinflammatory disease all the time. Compare test result during and before or after the attacks. This will give you a clue. CRP may be significantly elevated in certain autoinflammatory, typical, the classic one, inflammazomopathy, but may be normal in interferonopathies. So you have to keep it in mind. Normal inflammatory markers does not rule it out. And the serum amyloid A can be used to detect and monitor inflammation in systemic autoinflammatory disease. Now, we have, as I said, it's wide spectrum. Some autoinflammatory affecting the bones, some affecting other organs as a prominent system involvement. So if you have a patient with inflammatory bone disease, probably you need to consider the X-ray, bone scan, MRI, or this is for inflammatory bone disorder. And for the interferonopathies, all the time you need to consider brain imaging, especially in presence of neurological manifestation, even if it's mild, because they may be lack association between the imaging findings and the clinical manifestation. And regarding the genetic testing, of course, if it's available, this is very helpful and will narrow the differential diagnosis and spot the diagnosis. But you have to be careful. The presence of genetic test positivity does not mean the diagnosis. All the time you need to explain it in the light of the phenotype manifestations, especially if it's a new gene variant. If it's well known, this is easy to consider and to make a diagnosis. So you need to remember also genetically defined systemic autoinflammatory represent only a small subset. So most of the autoinflammatory diseases, they have no genetic test positivity yet. However, with time, probably people, they will be able to find more and more. And of course, the autoinflammatory disease will be more common in high consanguineous society. And I heard from Jatri yesterday that consanguinity in Sri Lanka up to 25. In our society, maybe more than 60 persons. So we have many cases because of the high consanguinity. This table just, or this photo is just to show or to give you a clue. Some diseases probably present with peculiar clinical manifestations. So if you see a patient with fever, serositis, and arthritis without other manifestation, and they have regular attacks in between, they are okay, probably you will entertain the possibility of a MF as the first differential diagnosis. However, if you see a patient with periorbital swelling or edema with the myalgia and attacks, probably you need to consider TRAPS. And if you see a patient with interstitial lung disease or intracranial calcification, you need to think about interferonopathies. At least as a clue, then you will proceed and you will tailor your treatment accordingly. Now, definitely presence of genetic variant will make your life easy for a diagnosis. However, you can make a diagnosis based on the clinical manifestation, especially in certain condition with lack of or access to the genetic testing. And this is from Eurofever Brento clinical classification criteria for many autoinflammatory diseases. I will not go through it, but you can find it easily. You apply it, and with high sensitivity, high specificity. So again, number one, you need to exclude others, and you will end with this items and apply it for this classification. This is a classification, not diagnostic, at least to narrow your differential diagnosis. So So the clinical feature overlap among systemic autoinflammatory disease and means that there is diagnostic challenges, and many conditions may involve multiple pathways and fit into various pathogenic categories. So identification of single gene defect enhance understanding of clinical variability in rare systemic autoinflammatory disease. So given the complexity of these diseases, the diagnosis still represents a challenge, and probably the first step, as I said, the clinical suspicion and guided by the hallmark of the disease. Now, the timeline for functional and mechanistic analysis is much slower than disease gene discovery, and revealing the functional effect of these defects remain a challenge. So the most important to remember, if you have a gene mutation, you need to ask yourself, is it a causation or association? So if it's well described before, it's easy to say this is the diagnosis. If it's novel gene mutation, means you need to do further assessment in terms of functional assay to prove it is pathogenic and related to the phenotypes. Saying that there is one entity called syndrome of undifferentiated recurrent fever, or SIRF, means this will not fit in any of the disease entity or autoinflammatory disease, and there is no genetic testing for this, and all the time the genetic testing is negative. However, they have recurrent fever episode, they have unidentifiable cause, lack of diagnostic criteria, and of course exclude other conditions. This is a new proposal, and people talk about it, and unfortunately this represents a good number of patients, and this is growing because the genetic test cannot answer all the diseases, and probably those patients, they don't present with typical or the same like other categories, so they lump it under this umbrella, what we call it SIRF, or syndrome of undifferentiated recurrent fever. I will not be able to discuss the treatment because it's beyond the scope of this presentation, but as a conventional approach, all the time we need to consider colchicine because it's a relatively safe medication. If you feel comfortable, this is not malignancy, not infection, you may consider short course of steroid as a treatment. And according to the phenotype, molecular characterization of systemic autoinflammatory, probably you need to tailor your medication treatment. But in general, interleukin-1 blockade is the main medication considered, and nowadays also because of interferonopathies considered as autoinflammatory diseases, JAK inhibitors also one of the options for the treatment. So what are the consequences of delayed diagnosis? Of course, unnecessarily workup, keeping doing and repeat labs result test without benefit, unnecessarily treatment, especially antibiotics or conventional DMARDs, missed school work, stress for the patient, the family, and the physician, and also the cost of repeated medical visits. I will give you just brief cases just to wrap or recap what I have been saying so far. This is a 3-year-old. I will go back to the first case I present. Just remind you, it's a 3-year-old. She's a 3-year-old girl with recurrent febrile episodes. In between, she is fine. She presented with fever, abdominal pain, arthritis, and we found she has high serum amyloid A. So what is the most likely diagnosis? Any thought, consideration? This is typical case of FMF. Okay, this is typical case of FMF. So let me just brief you about the FMF. There are different classification criteria. Till Hashemore criteria, this is established for adult patients. However, it have been validated for pediatrics. And there we have also pediatric criteria, because FMF is prevalent in Turkey. They call it Turkish pediatric criteria, and easy, more sensitive, more specific for patient with FMF. If the patient has present with at least 2 out of 5, this is very sensitive and specific for FMF. And also we have a Brinto or Eurofever Brinto criteria. If you have the genetic testing, of course it will be easy, but if you don't have it, you can apply it without presence of genetic testing. And again, it's very helpful and useful to apply it for your patient. Now, FMF is the most common monogenic systemic autoinflammatory disease. Patient typically present between the age of 5 and 15 years. The diagnosis is based on clinical findings rather than genetic testing. And the clinical features: brief episodes, less than 4 days. 95% of patients present with serositis, mimicking acute abdomen. This is due to neutrophil infiltration in the peritoneal cavity, and most of them they present with arthralgia, arthritis, and during attacks they have high inflammatory markers and normal between attacks from the clinical and laboratory. And there are maybe some triggers like infection, exercise, cold, emotional stress. And if we talk about the genetic part, it's due to gain of function, mutation in MIF gene, encoding byarine, and there are different gene variants. The most common one, and maybe more serious, is M694V, and this is maybe associated with high risk of amyloidosis, and probably those patients present early on, and they have more attacks, severe attacks, and as I said, high risk for amyloidosis. Any organ can be affected, but I already mentioned the most commonly affected, and they may present also with skin lesion. If you see it for the first time, you will think about cellulitis, and this is what we call it erysipelas rash. It's painful, well-demarcated rash, and interestingly, some patients present with HSP-like rash. And if you see a patient with recurrent HSP, you need to consider FMF. And interestingly, we have few patients present or managed in the referral hospital as recurrent HSP because they couldn't control the patient, the disease. They refer the patient to us, and we entertained the possibility of FMF. On colchicine, everything settled down and no more attacks. And some patients may present with sacroiliac joint involvement as well. So these are the exceptions, but you may see patients like this. So the treatment, colchicine is the mainstay of treatment for FMF. It can prevent amyloidosis, and still there are percentage of patients probably have partial response or maybe not responding to colchicine. On those patients, you need to consider interleukin blockade, namely anakinra or canakinumab. But you have to remember also, typically FMF attacks become less frequent and less severe with age. As they grow up, maybe they will improve, but you cannot depend on that. You have to treat your patient. So the second case is a 5-year-old girl presented at age of 9 months. This is one of my patients also. 2 months history of intermittent fever, left thigh swelling and pain, as you can see it here. The thigh is swollen, And also you can appreciate there is some abnormalities. She had right mandible painful. The right mandible was painful and swollen. There are no other associated or other history was unremarkable. And she had high inflammatory marker. What do you think the diagnosis? This patient came to me from the hematology oncology, was referred as a case of bone or to rule out bone malignancy. And then she moved to orthopedic, then she came to us. And of course, this patient needed bone biopsy. And they did bone biopsy and it showed no malignancy, negative culture, and showed evidence of osteomyelitis. So what is the diagnosis? Okay. This is a bone scan because I told you she had right painful mandible swollen. And interestingly, you can see also the ribs here are unfolded and was not complain of any, or the mother didn't discover anything. So this is most likely inflammatory bone disease. Yes, but the genetic test was negative, so we ended with this is just CRMO or chronic recurrent multifocal disease. And this is what we did. We got after a treatment. Simply we gave her pamidronate and short course of steroid. Everything settled down, and this is her femur after a while, and she's fine, alhamdulillah. This is not the same patient, but if you can appreciate any abnormalities, those who are in the back. Did you see anything from the X-ray? Okay, I will show you this one also. Maybe more easy to pick up. So you can see there is some abnormality. If you compare the clavicle here and here, there is some abnormality, and obviously there is also ballooning and change in the bone itself. And this is again osteomyelitis, CRM, or inflammatory bone disorder. So the inflammatory bone disorder are classified as systemic autoinflammatory disease, and there are different names. I prefer to call it inflammatory bone disease. It can be isolated, it can be multiple, it can be recurrent. CNO, they just limit it to bacterial, chronic non-bacterial osteomyelitis. But again, bone, it can be infected with fungal infection, so it's not only bacteria. So I prefer to call it inflammatory bone disorder. And these cases have chronic relapsing inflammatory osteoarticular disorder, and it might accompanied by skin eruption like psoriasis. They may present also with the most common affected area is the clavicle, and it can affect also the mandible, the vertebrae as well. And as Dr. Soma mentioned, there is an entity called Majeed syndrome. This is monogenic form due to gene variant called LPI or LPN2 gene. However, the most common type is sporadic. There is adult equivalent for childhood onset called SAPHO, synovitis, acne, pustulosis, hyperostosis, osteitis, and the diagnosis again of exclusion. You need to rule out malignancy, you need to rule out infection before considering this diagnosis. So the third case, probably I will end with that, a 4-year-old boy experiencing recurrent episodes of high fever lasting 3-7 days, accompanied by sore throat, pharyngitis, painful mouth ulcers in terms of after stomatitis, swollen tender cervical lymph node adenitis. He experienced periods of complete wellness between episodes, no identifiable triggers. The attacks lasted around 5 days, unaffected by NSAID or antibiotics. So he keep present with the same attacks. So the workup for bacterial, viral, and others inconclusive. So what do you think the diagnosis? So I give you a hint: pharyngitis, aphthous stomatitis, adenitis. So this is what we call it PFABA, and this is probably the most common polygenic systemic autoinflammatory disease. There is no genetic defect. So periodic fever, aphthous stomatitis, pharyngitis, adenitis, usually developed before 5 years of age. No genetic defect have been identified, and characterized by febrile episodes every 2 to 6 weeks, lasted few days, and patient may present with arthritis, GI symptoms, and splenomegaly. No genetic test required in those patients. So interestingly, low dose of corticosteroid might solve the problem, and some physician or literature claimed one or single dose of corticosteroid will be enough. However, in our practice, probably they need more than this, and maybe colchicine will help them. And there are reports tonsillectomy may also put the patient in full remission. So why should adult rheumatologists know about systemic autoinflammatory disease? Children with confirmed diagnosis will reach adulthood, and they will come to adult rheumatologists. So they should be aware about these diseases. And diagnostic delays, maybe the pediatricians are not good enough, or the pediatric rheumatologists are not good enough, and he will not make a diagnosis till the patient reach adulthood, and the adult rheumatologist will be smart enough to make a diagnosis. And the disease may express symptomatically in adulthood. Some patients, nowadays there are disease diagnosed or appeared or developed in the adulthood, and as I mentioned, Still's disease, adult onset Still's disease, gout, considered as autoinflammatory disease. And there is a new entity called Fiscus. This is purely adult systemic autoinflammatory disease. So in conclusion, systemic autoinflammatory disease need to be considered in case of unexplained recurrent fever. These are primarily diagnosed in children, with adult cases usually due to diagnostic delays. Adulthood systemic autoinflammatory diseases are usually associated with low penetration mutation and milder and atypical symptoms. Classification criteria are recommended for patient inclusion in clinical studies, but are not suitable for diagnosis. So you have to keep high index of suspicion. With that, I will stop, and thank you for your listening.
Okay. Thank you, Professor Sulaiman Al Mayouf, for very interesting presentation. Now may I invite Dr. Tilni Hemachandra, acting consultant rheumatologist at DJ Champar. Over to you, Tilni.
Good morning, all of you. Thank you for giving me this chance, and I would like to thank Dr. Jayatri Jagada Madam for her continuous support for the doctors working in periphery. So this is a girl. I was newly appointed to this hospital, and this is a 6-year-old girl. At that time, the presentation was right elbow pain, swelling, and difficulty in extend her elbow. She also complained of intermittent fever, but then there was no detectable fever when I saw her. And also she complained about a few diarrheal episodes along with some abdominal pain. She was on colchicine and cyclosporine for a rheumatological condition I've mentioned here, but then we would like expert panel opinion about the diagnosis. However, with regard to the diagnosis also, the genetic tests were not performed, so I'll keep the diagnosis open. And on examination, she had short stature, she was afebrile, and on examination of the joints, the rest of the joints were all right except for the right elbow joint, which showed active synovitis, as well as with reduced range of motion, especially with fully extension of the elbow. The rest of the system examination and examination was normal, basically. So if you look at the past history, starting from the birth history, her parents were consanguineous, and this was the first child, and with a normal antenatal perinatal period. And there was no significant family history, and the parents were healthy. There was mention of a diarrheal episode at the 6-month, which I have not included here, and that has been spontaneously resolved. That was around the time she was weaned off from breast milk, and the peculiar time was this 1.5 years, at the age of 1.5 years, where she presented with intermittent fever and about 1 to 2 episodes per month, and the highest reach was 102 degrees Fahrenheit, and a single episode had lasted about like 3 to 4 days. And this point, of course, I asked from mother just last night whether she was well between episodes. She was not quite sure, to be honest. What she mentioned was at any point there was one joint involved, but then with medication it wear off. And there was multiple joint pain and swelling. Initially started with ankle joint, then move on to knee joint and elbow joint, and that was asymmetrical involvement as well. And there was a maculopapular rash, itchy, which started around in bilateral shins and then went up to upper limbs, buttocks and necks. And she said sometimes there are small blisters, and these blisters will rupture, and there was a colorless fluid. Unfortunately, I don't have the pictures of that. So there has been episodes of loose stools again, and so I gathered the information from the clinic notes as well. There has been a mention about oral ulcers as well at one encounter. And there has been a lymphadenopathy. This was the only time I noted her to have this lymphadenopathy. And -3 standard deviation range. And the investigations performed at that time showed a high WBC count, but interestingly, lymphocytes were a little on the higher side, and there was low hemoglobin and high platelet count with very high inflammatory markers, ESR and CRP, but the ferritin had been repeatedly normal. And the general medical team the pediatric team had done extensive infection screening, which was negative, except for serology being positive for Candida antibodies. And scan abdomen, however, the hemoglobin, the blood picture done at this point revealed infection or inflammation with iron deficiency anemia, and the HPLC had been negative for any hemoglobinopathies. CCT abdomen done at this point revealed hepatosplenomegaly and paraortic lymphadenopathy as well. So the lymph node biopsy had been reactive, and the bone marrow biopsy was not showing any atypical cell infiltration. 2D echocardiogram showed hyperechoic myocardium and pericardium, and there was a comment saying early inflammatory pathology to be excluded, but then the subsequent echoes had been normal in the tertiary care hospital. her ANA had been positive with a cytoplasmic pattern. dsDNA was negative. Complements were on the higher side, actually. So, so this was so she has been followed up since then, and there has been a couple of times where she was defaulted as well. So I just put in this chart to summarize. So 2020 September was the first time she presented to the hospital, and that was 1.5 years duration. So as other than the high ESR and CRP, there is slightly higher globulin as well, but we have not done specific assays to see whether there are certain immunoglobulins are higher or not. And we have given her treatment with NSAID, and a month later, still the ESR has come down. CRP is also markedly reduced, so but the joint pains had been still there, and we had started her with presumed diagnosis of JIA. We have started her with MTX with prednisolone, and there has been a couple of hospital admissions, defaults, and between these two periods, nearly a year. And then we have tried cyclosporine, and then around 2022 February time, we have done colchicine, and we have started on colchicine and predni, and since then we've been using these alternatively and continuously. However, there has been periods where she was not able to purchase colchicine because of the colchicine being out of stock or difficulty in purchasing from outside. And even though we have stopped prednisolone at some point, she has taken over-the-counter prednisolone. She has given over-the-counter prednisolone as well. What exactly the diagnosis, and whatever the diagnosis is still under control, and colchicine being unavailable and the genetic testing is unavailable, and time to time colchicine, and parent being given the child over-the-counter steroids. And last time when I spoke to mother, doctor, I don't mind if she has joint pain or not. Please do something for the short stature. Thank you. That is sort of the end, and I know there's a lot of gaps in the history, and maybe difficult to get the whole picture, but.
Going for discussion, may I ask whether it's possible to be hyper IgD syndrome, and immunoglobulin levels are not done, I think.
First of all, thank you for this nice, challenging case. But probably, may I ask a question? I don't catch if you perform endoscopy for this patient, since she has loose motion, failure to thrive, iron deficiency. At one time, she has low serum albumin with oral ulcers, loose motion, joint pain, probably early onset IBD or inflammatory bowel disease need to be considered. So I don't know, was it considered?
So we have not performed an endoscopy on her, but thank you for the thoughts. We'll think about it.
At least when I heard the presentation and I was talking to Jayatri and Liz, from systemic autoinflammatory disease. Of course, the early onset is a point, and the consanguinity is another point, and the repeated attacks, or she has this constellation. Probably I will consider haploinsufficiency A2. This is or 20. This is almost similar to inflammatory bowel disease or maybe Behçet disease. This is overlap between. So this is at least from systemic autoinflammatory disease. I will think about haploinsufficiency, but as other differential diagnosis, probably early onset IBD also. I don't know if my colleague agree or.
I just wanted to comment on the approach. It was a really good presentation, Tilini. Thank you for that. When we are seeing a child with recurrent episodes of fever, just like Professor Sulaiman said in his talk, we need to consider two things. One, is this a periodic fever syndrome? Meaning there are these episodes of fever and complete wellness in between on history and even in the labs? Or is this a child with a chronic inflammatory condition, could still be autoinflammatory, with flares, and then periods where he or she has no symptoms, but probably has some chronic inflammation? If in between apparent fever episodes there is still systemic inflammation on the blood tests, then we are dealing with the second group, not periodic fever syndromes, but a chronic autoinflammatory condition. And that is what we thought about when we heard the patient, that you showed a very nice lab report from September to October 2020. The ESR was 130, and then in October, 96. So to me, this speaks of something more chronic. The fact that the child is not growing well with the parameters under the third standard, -3 SD, also speaks to something more chronic. And so because of that, we were thinking of VEO-IBD, which is very early onset IBD, or in any young onset recurrent aphthous ulcers and diarrhea. We also think of haploinsufficiency of HA20. And if among the audience you realize, I would never think of HA20, that's okay. That's when you refer to pediatric rheumatology. But the first thing to think about is, does this child have a periodic fever syndrome, or is it a more chronic inflammatory condition?
Yeah, I think both of them have outlined the issues really, really well. Again, excellent presentation, and this really highlights the dilemma. So I think you laid it bare for the people in the audience to see how the picture of this child has evolved over the years. And the failure to thrive is showing you that the inflammation is ongoing. Whatever we are doing, the inflammation is ongoing. It's not being controlled. IBD definitely needs to be ruled out here, and a VEO IBD. Now, basically, it tells me that your next two steps, fecal calprotectin, if you can get it done, would be a good, a pointer towards the possibility of IBD. Doing scopies in this child, upper and lower GI scopies, and looking at the histology, and again whole exome sequencing, because when we say VEO IBD, we mean that you're looking for the various mutations that are identified with VEO IBD, and there's a whole lot of them. So, and again, that is also important. I think if that's difficult for you, there are actually several centers worldwide where you can collaborate with, and you can send them your samples, and they will gladly do the exome sequencing for you. And there are many centers which have research grants to study these children, and they would often be happy to collaborate with you. I know that PGI Chandigarh, Dr. Sujit Singh's team, they have a good immunology lab, and they are willing to collaborate. So Dr. Deepthi Suri, who's currently the president of our Paediatric Rheumatology Society India, is actually the person who heads the autoinflammatory services in PGI Chandigarh. I can give you her email offline, and
Thank you.
you'll need to establish a channel where you can send samples and you can go through. Or there are many other centers too, I'm sure, where you can do this, because once you start confirming diagnosis for patients, then you will start seeing more. And when you start seeing more, you will start understanding more about how these children behave, how they need to be treated, and then applying the pressure on your government to get you the necessary resources for them. The patients will do it too. So that will help. So that's how these processes get set up. Thanks.
Thank you.
I think, as Prof said, hyper IgD also can be one of the differential diagnoses, especially with this oral ulcers, lymph node enlargement, GI symptoms. They may present with the same presentation. I'll take this opportunity. We have ABLAR network for autoinflammatory disease already we submitted, and hopefully we'll get a grant. In these cases, probably we can get samples from those who need to collaborate and to do it. So hopefully we'll announce it soon.
Thank you. I forgot that you are able to accept samples from elsewhere. Really sorry.
Referred ultimately to the pediatric rheumatologist. She scratches the head, I go so blind at times because I told Liz the other day, sometimes I feel that a whole beautiful case is hitting my face. I don't know what that is. That's how I feel exactly. Because it's so difficult. You clinically suspect there's no way to confirm the diagnosis, even if the genetic tests are done. It's so difficult. Only a few people to talk to, to get the true picture out of it. And that's what the whole country scratches the head then.
Well, this is common.
Yeah.
This is everyone.
Thank
This
you.
is our daily practice. We are seeing cases we don't know what is it, so we have to think 10 times before saying anything. So I mean, this is not unusual at all.
And to the younger doctors, I want to say, you help Madam and even us by knowing your patients well. You know their history and their physical examination well. You don't have to know the answers because, as you can see here, we don't know the answers. We're guessing. But we can only make a good guess because you get a good history, physical exam, and you know the patient's lab parameters. So good medicine always starts with that, not ANA and genetic tests. Like Professor Sulaiman said, even if you get a positive genetic test, it is only useful if that genetic mutation matches the patient's clinical presentation. So you still have a very important part to play.
Yeah, we saw a patient, Liz and myself. I think it's actually Esandi. We have a genetic diagnosis, but I don't know whether that helps. Yeah.
May I ask another question? Can immunoglobulin levels be high in inflammatory bowel disease? Is it in this patient immunoglobulin levels are high?
See, the diagnosis of pediatric inflammatory bowel disease is very different from adult. Actually, chronic inflammation, failure to thrive, one of the DDs in your mind should be inflammatory bowel disease in a child. Recurrent oral ulcers is one pointer. Don't wait for bowel symptoms. Okay, don't wait for bowel symptoms. So that is late in pediatric IBD, especially Crohn's. So you should be doing colonoscopies at a much earlier stage and picking up the diagnosis for these patients. It's very different from adult.
In pediatrics, if the Crohn's affects only the small bowel, then they may not have diarrhea at all, because diarrhea only comes when there's inflammation of the colon. So like Dr. Suma said, If you don't feel like the child needs a colonoscopy yet, a fecal calprotectin is very useful. Can you do fecal calprotectin here? Okay.
It's done. There was a previous diagnosis of a cold antibody. How did that come through an investigation? Pardon? But there was a sort of testing done for the cold antibody, so okay, so it's a clinical picture. They thought that it's possible, and also what I noticed was there's a very high lymphocytosis at the beginning. Does that sort of tells us anything?
Yes, because I've been in pediatric, the LRH for over a few years as a pediatric, managing pediatric patients. I also have seen inflammatory bowel disease patients presenting just with heel pain. Yeah, young girls presenting heel pain, and then actually that patient had stools in urine, and it was due to fistula, inflammatory bowel disease, Crohn's disease. Yeah, presentation was there.
It's the HLA-B27 spectrum. The HLA-B27 mediated diseases are a spectrum. So you can see enthesitis, lower limb arthritis. You can see many of the features that you see in that spectrum, along with IBD as well, uveitis. There's so many, like the gastroenterologist will talk about extra-intestinal features of IBD. Rheumatologists will talk about extra-articular features of IBD and mention Crohn's as one. So it's just a perspective.
Yeah, so as a peds rheumatologist, how the IBD come to us first is if they present with PUO or if they present with what looks like enthesitis-related arthritis, a lot of enthesitis, but the clue is a lot of inflammation because this is a systemic condition and the child may not have any GI symptoms. So PUO, enthesitis, bad, or oral ulcers, yes. If you think about it, the mouth is part of the GI tract. So our gastroenterologist will say that oral ulcers are not extra-intestinal. It's part of the intestine.
Touching a little on it in my talk on vasculitis.
Yeah, but in this patient, for sure, patient disease is the, let us say, the sporadic type of haploinsufficiency A20. So they have similar presentation, and even at the level of the histopathology. So it's difficult to differentiate, but think about it, then you will make a diagnosis.
I just wanted to ask, what's the experience with CRMO here in Sri Lanka? Do you get to see many patients? Are you able to do whole body MRIs?
I have about maybe 25-30 cases of CRMO.
Very good.
And our orthopedic surgeon is very good at it. He directly says, no biopsy, this is CRMO. Sometimes... Now he says this is CRMO, no biopsy needed. Yeah. When we ask for biopsy, so he's so sure because he has seen more than me. I follow up about 10 patients roughly. There are instances that they responded to. I don't know. They respond to different things. Some responded to NSAIDs. A few of them to methotrexate, one very aggressive one responded to golimumab. Interestingly, this girl got a huge rash on the scalp, and I told Lisa that she had a horrible forearm bone CRMO, and her inflammatory markers were high. I have many kids who don't have inflammatory markers high. It's so heterogeneous, I don't know. So somehow on bisphosphonates, and this girl who responded very well, her ESR came from 90s to 10, 15, but unfortunately with the rash, we sent to dermatology when they have, the dermatologist has suggested golimumab caused this, and I lost the patient. But it can be sappho and that range of things. I don't know what was what. But inflammation started, controlling, but then she got the rash. I don't know which is which. But there are cases, some have gone spontaneously resolved. Some cases quiescent for a time and then coming back again. I really don't understand it very well.
Thank you. I mean, that's very interesting. You don't need a biopsy if you have the classic chronic recurrent multifocal picture. If when you have only unifocal CNO, chronic non-bacterial osteitis, we generally do advise doing a biopsy to be sure. Most patients will not have very elevated inflammatory markers, you're quite right. And when you do have very high inflammatory markers, sometimes you have to think about the syndromic forms, IBD being coincidental, psoriasis, psoriatic arthritis ongoing with the patient, or a HLA-B27, axial spondyloarthropathy evolving along with the CRMO. These are all possibilities, plus monogenic forms in the very younger children. That's all that is actually potentially possible. But it's great actually that you're picking up and managing these patients. And yeah, there are different treatments and different things work for different people. Yeah.
And I have two sisters of the same family. They look phenotypically much like progressive pseudorythmatoid dysplasia. Two girls in the same family. They have high inflammatory markers. Do you expect that in this type of skeletal dysplasia? But it is like pseudorythmatoid phenotypically. When I read the literature, the clinical picture is same, the progressive bony deformities, but they always have high inflammatory markers. I have tried some methylprednisolone to see whether it comes down. I don't know what that is either. Any
Just if I made a small comment, it's healthy and nice to see difference between the practice. Myself, I don't treat or make a diagnosis of CRMO without biopsy.
Okay.
So I need to do biopsy to make sure I don't miss any slow growing infection or maybe malignancy, because I will not forgive myself if I miss a case labeled as CRMO and turned to be infection. I have one bad experience referred to me from immunologist, child with multiple bone lesions, and she had some psoriatic-like rash. And they managed her or investigate her as immune deficiency. Then after workup, they said, this is not immune deficiency, please take over. And they did biopsy. And the initial biopsy was negative. And we treated her with, as usual, steroid, and we initiate anti-TNF because the response was not that good. Later on, she had progressive bone lesions. We repeat biopsy, and it turned to be TB. And we did genetic test for the second time and came positive for STAT1 deficiency, which is immune deficiency and complicated by TB. So this is bad experience to me. So before and after this case, I used to do bone biopsy, even with, classic presentation, because it's a diagnosis of exclusion. I know some people, they don't do it if they have, especially those patients with other clinical manifestations or unwell looking, definitely you need to do bone biopsy, definitely. Yeah.
I mean, you don't expect many systemic features with CRMO. So if there's anything atypical, you should definitely go for a biopsy. We have some patients who have only diaphyseal lesions, but obviously that is something we will confirm finally as CRMO only after we've done a biopsy. But it is reported that sometimes we've had biopsies in CRMO well noted and fitting all criteria, where they have seen granulomas, where they have seen, there are many other changes that you can see, because even granuloma is like a long-standing inflammatory change that can turn up. That doesn't necessarily mean the patient has tuberculosis. All the other workup is negative. So it is a kind of a holistic diagnosis at the end of it, but you obviously have to think about different options when you're seeing the patients here.
I think we finished.
Okay. Thank you very much, Professor Sulaiman and the expert panel for this interesting discussion. Yeah. So now tea will be served in the same floor, and please come at 10:30 a.m. Thank you.
Thank you. That's great.
You should see all the CRM.